Major intracellular and extracellular electrolytes. Electrolytes. Electrolytes are the substances that ionize when dissolved in a suitable solvent like water. Example: NaCl, KCl, CaCl2, MgCl2, NaHCO3, KH2PO4, K2SO4. Electrolytes. Body fluids are aqueous solution of organic and inorganic substances. Different body fluids have different composition based on their functions and can be classified into intracellular fluid. Example: fluid present inside the cell comprises 45 to 50% body weight and cytoplasm. Extracellular fluid present outside the cell. In that in that, interstitial fluid comprises 12 to 15% body weight, vascular fluid or plasma comprises 4 to 5% body weight. Electrolytes. All the body fluids are separated from each other by selectively permeable membrane, that is permeable to water. The certain organic, inorganic entities and permeable to large molecule, having selectively for different substances like sodium, potassium, magnesium, etc. Composition of each fluid, that is electrolyte, present in is maintained both ionically as well as osmotically by different body mechanism under normal circumstances. Maintenance of a constant environment in various cells, tissues, body fluid, physically as well as chemically, is termed homeostasis, mainly including pH control, ionic balance, osmotic balance, etc. in different body fluid. Common inorganic electrolyte associated with homeostasis include potassium, sodium, calcium, then HPO4, H2PO4, chloride, CO3, HCO3, magnesium, ferric iron, ferrous iron, iodine, zinc, copper, cobalt, and manganese, etc. Electrolytes. All the electrolytes have a definite concentration pattern in different body fluids and they are distributed accordingly. Some of them are required in trace quantities like MO, CR3C, etc., whereas some are required in quality quantities as high as 5 to 10 gram like sodium chloride. Their reabsorption, absorption, metabolism, primary physiological function vary considerably. Their deficiency as well as excessiveness may lead to various clinical manifestation of various metabolic disorder. Primary functions of electrolytes including maintenance of electrolyte balance, including acid-base balance and osmotic equilibrium in various body fluid, to facilitate a specific metabolic function through supply of specific ion to body fluid associated with particular cell or tissue or organ. Electrolytes. Major interest electrolytes include sodium, potassium, calcium, magnesium, phosphorus, hypophosphorus, chloride, HCO3, etc. Functions of major physiological ion. Chloride. First example: major extracellular ion amount present 50 mass equivalent per kg. Daily requirement 5 to 10 gram as NaCl. Main sources: table salt, animal food. Absorption: absorb completely. Elimination: eliminated with urine from blood by glomerular filtration and reabsorbed by DCT some amount through sweat. Functions: maintenance of hydration, osmotic pressure, normal electrolyte balance, acid base balance, gastric acid. Clinical condition of indeficiency, hypochlorhydria, and clinical condition in excessiveness, hyperchlorhydria. Functions of major physiological ion. Second example, sodium. Major extracellular ion constituent 90% extracellular cations. Amount present 1.8 gram per kg. Daily requirement 3 to 5 gram as NaCl. Main source table salt, salty food, baking soda, some vegetables, animal food. Absorption: absorb completely and readily. Elimination: eliminated with urine from blood by glomerular filtration and reabsorbed by DCT, some amount through sweat. Body content regulated by kidney. Aldosterone promotes reabsorption from DCT. Functions: maintenance of hydration, osmotic pressure, buffer constituents, acid base balance, cell membrane permeability, muscles contraction, that is muscle irritability, then carbon dioxide transport, transmission in nerve impulses in nerve fiber, clinical conditions in deficiency known as hyponatremia, and clinical condition in excessiveness known as hypernatremia. Functions of major physiological ion: calcium, almost 99% present in the bones and teeth, remaining mainly in extracellular fluid. Amount present 22 gram per kg. Daily requirement 1 gram. Main sources: milk and milk product, egg, green vegetable, some fishes. Absorption: absorb poorly 20 to 40%. Varies depending upon body requirement. Vitamin D, lactose, acidity increases the absorption, whereas fat, phthalate, oxalate, low dietary phosphate intake decreases the absorption. Elimination: eliminated in feces, blood, calcium level along with phosphate level and their mobilization into bones are controlled by parathyroid hormone. Functions: formation of appetite, hardening of bone and teeth, blood coagulation, muscles contraction, neuromuscular irritability, cell membrane permeability. Clinical condition in deficiency: hypokalemia, rickets, poor growth in children, hyperexcitability, tetany. Clinical condition in excessiveness known as hyperkalemia, fatigue, muscle weakness, constipation, anorexia, irregular cardiac function, renal failure. Functions of major physiological ion. Next one is bicarbonates. Present mainly in extracellular fluid. Amount present 25 to 30 mass equivalent per liter blood. Daily requirement traces. Main sources: citrus fruits, milk, etc. Absorption: orally taken bicarbonate salt will be neutralized by gastric acid. Organic acid, radical, lactate, citrate, etc. are converted into bicarbonate in vivo. Some CO2 is converted into carbonic acid and bicarbonate ions. Elimination in the form of CO2 through lungs. Functions: maintenance of physiological acid base balance, CO2 transport, maintenance of hydration, gastric acid, electrolyte balance. Clinical condition in deficiency known as metabolic acidosis via in uncontrolled diabetes with ketosis, renal diseases, poisoning by acid salt, excessive loss of interstitial fluid by vomiting, diarrhea, colitis, hyperemia. Then clinical condition in excessiveness known as metabolic alkalosis, intake of large quantities of alkali. Functions of major physiological ions: phosphate, Anion present mainly in intracellular fluid. Amount present 12 gram per kg. Daily requirement 800 mg. Main source for phosphate from milk, dairy product, oatmeal, whole grains, legumes, nut egg yolk, liver, kidney, etc. Absorption absorb from intestine. Elimination mainly in urine, small amount in feces. Functions predominant constitution of bones and teeth, constituents of HPO4 and H2PO4 buffer, cell phosphoprotein, cell phospholipid, nucleoprotein, hexose phosphate, metabolic intermediates and cofactors, ATP, NAD, FAD, etc. Clinical condition in deficiency known as hypophosphatemia and clinical condition in excessive known as hyperphosphatemia. Next function of physiological ion potassium. Cation present mainly in intracellular fluid. Intracellular concentration is 23 times more than extracellular concentration. Amount present 2.6 gram per kg. Daily requirement 1.5 to 4.5 gram. Main source of potassium milk and dairy product, whole grain, legumes, vegetables, meat. Absorption absorb rapidly, active transport, sodium potassium pump. Elimination mainly in urine by kidney. Functions electrolyte, acid base, water balance, constituents of physiological buffer, muscles contraction, membrane transport, CO2 transport. Clinical condition in deficiency known as hypokalemia and clinical condition in excessive known as hyperkalemia. Next function of major physiological ion, magnesium. Cations present mainly in intracellular fluid. Amount present 0.5 gram per kg. Daily requirement 300 mg. Main source vegetables, legume, nuts, milk, whole grain, beans. Absorption absorb slowly. Absorption retarded by alkaline media. Elimination unabsorbed portion is excreted in feces. Absorbed magnesium is excreted through urine, bile, and interstitial secretions. Functions part of several enzymes involving phosphate metabolism, example transferase, constituents of bone, teeth, essential for protein synthesis, assure smooth functioning of neuromuscular junctions. Clinical condition in deficiency, confusion, tremors, chloroform movement, vasodilation, hyperirritability. Clinical condition in excessiveness known as hypermagnesia, nervous system depression, anesthesia, paralysis of skeletal muscles. Electrolyte imbalance. Physiological condition when distribution of electrolyte disturbed. Such situation, if persists for longer duration, can lead to prolonged fever, several vomiting, diarrhea, etc. Body tries to balance the electrolytic composition of different body fluid by homeostasis in normal circumstances. When the imbalance is beyond the capacity of body homeostasis or it can't be balanced by body itself, replacement by deficient electrolytes and discontinuing the intake of electrolytes which are in excess can restore the normal electrolyte balance. The electrolyte imbalance can be corrected by appropriate administration of formulations containing electrolytes, acids, bases, blood products, carbohydrate, amino acids, proteins, etc. Condition responsible for electrolyte imbalance. First, conditions leading to fluid and electrolyte imbalance, accident, hemorrhage, surgery, etc. Then in that cases, management of electrolyte required fluid and electrolytes. Second condition, diarrhea, vomiting, dehydration due to GI infections or ingestions of toxin, allergic substances. So management of electrolyte, fluid and electrolytes, then rehydration therapy will be provided. Then third one is drug induced electrolyte elimination, thiazides or loop diuretics, natriuretic drugs. Then management require administration of appropriate salt, example sodium chloride, potassium chloride, etc. Then fourth condition, retention of electrolyte due to excessive use of salt. Then in that condition, management of electrolyte required fluid free from excessive electrolyte. Fifth condition, metabolic disorder leading to acidosis or alkalosis. Management required appropriate electrolyte preparation for acute conditions to restore normally and treatment of underlying cause. Sixth conditions including deficiency of essential iron, nutritional excessive elimination. In that condition, management required appropriate salt. Then last condition include excessive presence of specific iron. Then management required discontinuing the intake of that iron and treatment of underlying cause. Electrolyte used in replacement therapy. Whatsoever the reason, when there is electrolyte imbalance inside the body and bodily homeostasis mechanism are not able to rebalance, replacement therapy is given. The electrolytes which are in excess are replaced by the electrolyte in deficiency. Commonly used electrolyte for replacement therapy include sodium chloride, potassium chloride, calcium gluconate, potassium gluconate, calcium lactate, dibasic calcium phosphate, and magnesium sulfate. Sodium chloride, first example for replacement therapy, chemical formula NaCl, molecular weight 58.44, synonyms common salt, nitricoridium or core sodium chlor. So sodium chloride is one of the most essential electrolyte involved in maintaining osmotic pressure in blood and body tissues. Major component of extracellular fluid. Normal plasma contains 140 mass equivalent per liter of sodium and 1000 mass equivalent liter of chloride. Daily dietary intake of NaCl is 5 to 12 gram as a taste enhancer. Equivalent amount is excreted from urine and sweat, maintaining the electrolyte balance. If taken in excess, it works as a saline diuretic. In nature, NaCl is distributed abundantly in the form of salt, that is rock salt, deposit and salt lake. Seawater can have 2.5 to 3% NaCl. Sodium chloride preparation from rock salt. Bore holes are drilled in rock salt deposit and water is run down to rock salt strata. Sodium chloride is dissolved in water forming brine solution. The clear brine solution is pumped above to the surface and its water is evaporated with the help of triple effect evaporator to obtain sodium chloride. From seawater, seawater contain around 3 to 3.8% of different salt, out of which 75 to 80% is NaCl. This can be this has been main source for manufacture of NaCl for hundreds of years. Seawater is filled in small artificial lakes, shallow pans, shallow tanks and allowed to get evaporated. The impurities are removed by dissolving so obtained salt in water and filtering it. Alum, lime are added to settle down all the suspended impurity. In pure form, NaCl is prepared by passing HCl gas through concentrated aqueous solution of common salt. HCl gas dissolved in water forming hydrochloric acid. NaCl insoluble in hydrochloric acid get crystallized, leaving the impurities in solution. Properties: colorless crystals or white crystalline powder, odorless, having saline taste. Freely soluble in water and more soluble in boiling water, soluble in glycerine and slightly soluble in alcohol. Storage: as NaCl is hygroscopic in nature, it should be kept stored in tightly closed container. Solution on storage may cause separation of small solid glass particles from glass container. Dose: orally 3 to 6 gram per day. IV infusions as per requirement. Sodium chloride uses electrolyte replenisher. 0.9% solution as a NS, that is normal saline, as wet dressing for irrigating body cavities, wound, tissues, as IV infusion, IV injections in electrolyte depleted situations. In oral rehydration therapy, hypertonic solution as emetic. Saline diuretics for bromide iodide poisoning. Taste enhancer. Assay: zero point 0.5 gram NaCl and dissolved in 50 ml water. Titrated with zero point 0.1 normal AgNO3, that is silver nitrate, using potassium chromate as a solution. Preparation of sodium chloride injection. NaCl in IV infusion: 0.9% weight by volume, that is plus minus 0.05%. Sterile isotonic solution of NaCl in water for injection contain no antimicrobial agent. The solution must be clear, used as a fluid and electrolyte replenisher. Isotonic vehicle irrigation solution stored in single dose container of glass or plastic. Sodium chloride hypertonic injection, hypertonic saline. 1.6% weight by volume, that is plus minus 0.08%. Sterile solution of NaCl in water for injection containing no antimicrobial agent. Solution must be clear, used as a fluid and electrolyte replenisher, stored in single dose container of glass or plastic. Compound saline chloride injection, also known as Ringer's injection. 0.86% weight by volume, plus minus 0.04% NaCl. 0.03% weight by volume, plus minus 0.0015% KCl, and 0.033% weight by volume, that is plus minus 0.003% calcium chloride and water. Sterile solution in water for injection containing no antimicrobial agent, filtered to make it clear and autoclaved for sterilization. Used as a fluid and electrolyte replenisher. Store in single dose container of glass or plastic. Compound sodium chloride solution, also known as Ringer solution. Solution of 0.86% weight by volume, plus minus 0.04% NaCl. 0.03% weight by volume, that is plus minus 0.0015% KCl, and 0.033% weight by volume, plus minus 0.003% calcium chloride, water in purified water. Used as a irrigation solution for external use, stored in tightly closed container. Sodium chloride and dextrose injection infusion. Sterile solution of NaCl and dextrose containing not less than 95% and not more than 105% of the stated amount. Official injections include percentage of NaCl 0.11, 0.18, 0.2, 0.225, 0.3. Then percentage of C6H12O6, that is dextrose, 55555. Percentage of NaCl 0.33, 0.45, 0.45, 0.45 and zero point 0.9. Then percentage of C6H12O6 5, 5, 5, 10, 2.5. Percentage of NaCl zero point 0.5, zero point 0.9. Then percentage of dextrose 5, 10, 10, 25. Used as a fluid, nutrient and electrolyte replenisher. Stored in single dose container of glass, plastic in cool place. Should not be used if visible turbidity is there. Preparation of sodium chloride tablet. Tablet of strength zero point 0.3 gram, zero point 0.6 gram, 1 gram, 2.25 gram. Prepared with some lubricant and binding agent. Used as a electrolyte replenisher. Stored in tightly packed container. Sodium chloride solution, normal saline solution, 0.9% weight by volume, isotonic solution, used as irrigation solution, wet dressing and isotonic vehicle, stored in tightly closed container. Potassium chloride, chemical formula KCl, molecular weight 74.55, synonym calicloridum. Potassium chloride is an important electrolyte, potassium being major intracellular cation, whereas chloride being major extracellular anion. It occurs in the form of carnalites, that is magnesium chloride, KCl and water. Salvites, mixture of NaCl and KCl, and the bed of solid salt of complex composition of Sills Lake, USA. Preparation by fractional crystallization or special fusion of flotation of natural minerals. In laboratory, it can be prepared by action of HCl on potassium carbonate. K2CO3 plus twice HCl gives twice KCl plus CO2 plus water. Properties: colorless, prismatic or cuboidal, crystals or white granular powder, odorless with saline taste, freely soluble in water and slightly more soluble in boiling water, practically insoluble in alcohol and ether. Uses in the treatment of potassium deficiency as oral replacement therapy, treatment of myasthenia gravis, antidote for digitalis toxicity. Dose 500 mg to 8 gram daily as per requirement. Storage: as it hygroscopic, it is stored in well closed container. Preparation: potassium chloride sustained release tablet contain 600 mg KCl equivalent to 8 mass equivalent. Strong potassium chloride solution, liquid in syrup, sorbitol base having 10 to 15% KCl. Potassium chloride injection 1.5 gram to 10 ml, 3 gram in 12.5 ml, 6 gram in 30 ml of KCl in sterile water for injection. Used in hypokalemia, digitalis intoxication, familiar periodic paralysis, diuretic therapy, hepatic cirrhosis with astrides, states of aldosterone, excess with normal renal functions, etc. Ringle solution and injection, oral electrolyte powder and solutions. The next example, calcium gluconate, chemical formula C12H22O14CaH2O. Molecular weight 448.4. It is a calcium D-gluconate monohydrate. Preparation: by boiling a solution of glucuronic acid with excess of calcium carbonate. Properties: white crystalline powder, odorless and tasteless, freely soluble in boiling water, sparingly soluble in water and insoluble in alcohol, ether and chloroform. Uses in the deficiency of calcium. The next topic, oral rehydration therapy. In the case of acute diarrhea, along with water electrolyte like chloride and sodium are actively secreted from the gut mucosa and there is a significant loss of these ions. If an isoosmolar solution of glucose and sodium chloride is administered orally, glucose and sodium are absorbed. Along with sodium water reabsorption, it is also promoted. This makes the physiological basis of oral rehydration therapy. Oral rehydration salts are composed of anhydrous glucose, sodium chloride, potassium chloride, and either sodium bicarbonate or sodium citrate. The dry preparations is mixed and with specified amount of water, solution is obtained is used for oral rehydration therapy. Then formula for ORS ingredient sodium chloride in formula 1 1 gram, potassium chloride in formula 2 1.5 gram, sodium bicarbonate in formula 1 1.5 gram, sodium citrate no quantities, anhydrous glucose 36.4 gram. For formula 2 sodium chloride 3.5 gram, potassium chloride 1.5 gram, sodium bicarbonate 2.5 gram, then anhydrous glucose 20 gram. Then for formula 3 sodium chloride 3.5 gram, potassium chloride 1.5 gram, sodium bicarbonate don't have any quantity, then sodium citrate 2.9 gram, anhydrous glucose 20 gram. These quantities are dissolved in 1 liter water. Formula 2 and 3 are recommended by WHO and UNICEF to control diarrhea. Then ORS formula sodium chloride 2.6, potassium chloride 1.5, trisodium citrate dehydrate 2.9, anhydrous glucose 36.5. WHO has released new formula for ORS. Physiological acid base balance. Similar to electrolyte composition, all the body fluids have definite pH for their optimum functioning and it must be maintained. Regulation of pH is essential for different biochemical processes taking place in different cells and tissues. Normal pH range of certain body fluid as blood pH 7.54 to 7.5, saliva pH 5.4 to 7.5, urine pH 4.5 to 8, gastric juice pH 1.5 to 3.5, duodenal fluid 5.5 to 7.5, gallbladder bile 5.5 to 7.7, pancreatic juice 7.5 to 8.2, semen 7.2 to 7.6. pH in individual organ is maintained by acid alkali secretion to suit optimum level. Acidic pH of gastric juice is maintained by secretion of hydrochloric acid in stomach by parietal cell in response to chemical stimuli like histamine at H2 receptor, acetylcholine at M2 receptor, etc. This low pH is optimum for functioning of pepsin which is present in the gastric juice. pH of saliva is 5.4 to 7.5 which is suitable for optimum functioning of pitralline. The action of pitralline is inhibited at pH 1.5 in stomach. The blood has pH range 7.4 to 7.5. As blood is the major fluid in the body, this is general pH which can be alert in an individual organ for optimum functioning of the organ. Different metabolic processes in body cell produce acidic product via carbonic acid from CO2 and water, sulfuric acid and phosphoric acid from protein and phosphoprotein, lactic acid and pyruvic acid from anabolic metabolism, and alkalis via bicarbonate ion from organic acid, salt like citrate, lactate, etc., which tends to alter the pH of the tissue, fluid, and blood. There are certain regular mechanisms which maintain the pH of the fluid to optimum. These mechanisms are buffer of the body fluid, respiratory mechanism, and renal regulation. Buffers, chemicals that resist the change in pH. Plasma contain MHCO3, H2CO3, M2HPO4, M2, MH2PO2, M organic salt, organic acid, and M protein and proteins, where M represents sodium, potassium, calcium, or magnesium. The ability of complex buffer system present in the blood to bind with the pH, ion, and neutralize acid is called alkali reserve of the blood. In case pH of the blood fall below 7.4, this reserve alkali react with excess of acid or H plus ions and their amount decreases. Such a conditions can lead to acidosis. Likewise, when the pH rise above 7.5, the excess of alkali use the acid reserve and situation of alkalosis can take place. Physiological buffer system prohibit sudden change in pH in body fluid, but in order to function optimally it requires for some mechanism by which some amount of acid base can be made available. Lungs and kidneys provide for such. Respiratory mechanism. When rate of respiration is slow down, CO2 which is acidic get accumulated inside the body and neutralize the alkali reserve of the blood and causes acidosis. When rate of respiration is higher, there is a excess excretion of CO2 which may leads to alkalosis. Thus, acidity and CO2 concentration are both stimulant for respiratory mechanism and can alter the rate as well as depth of respiration. In the situation of acidosis, H2CO3 is converted into CO2 and water and the CO2 is rapidly breathed out. In case of alkalosis, both acidity and H2CO3 content is decreased, so both respiratory rate and depth are decreased, leading to retention of CO2, thus increase in H2CO3 till the normal rate of MHCO2, MHCO3 and H2CO3 is reached. Renal mechanism. Kidney from ammonia which combines with acid produced by protein metabolism and excreted in the urine. pH of urine varies widely from 4.8 to 8, but in general it remains a bit acidic. Anyways, varies with the nature of diet and exercise, etc. Fixed acid like phosphoric acid, sulfuric acid, HCl, etc. are removed through the kidney. A 24 hours urine output with a normal individual contain equivalent of 20 to 40% 40 ml of zero point 0.1 normal acid termed as titrable acidity of urine. Disturbances in acid-base balance. Different physiological buffer system, respiratory system, excretory system work together to maintain the acid-base balance of the body. Defect in elimination of CO2 or any metabolic disorder can alter the pH of the blood and other body fluid beyond the physiological limit. Such conditions are termed as physiological acid-base disturbances and are classified as respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Thank you.